So people don't seem to realize the size or the scope of the services that we provide to Kitsap County. And I wanted to just show you physically who we are, where we are. This is the main campus of Kitsap Mental Health Services. We're located on off of, I think this is Wheaton Way or Highway 303. There's the Lowe's and the Fred Meyer. And and you can see that we have quite a large area there. We have at least 5 different buildings that house a number of different services, and we have satellite clinics as well. We serve over 7,000 unduplicated individuals in some mental health treatment capacity every year, and we have about 500 employees. Zooming in to some of the buildings specifically, up at the top, we have our crisis triage center. We have our addiction residential rehab in this top building here. See if I can get a pen right up here. We have our comprehensive outpatient services and our administrative offices located in this building here. This is our on-site pharmacy. This building here is our Madrona school. This is we have 24 students in an alternative school for children who have trouble operating in standard organized classrooms. Here we have an adult inpatient unit. Here we have our youth inpatient unit. And then down here at the very bottom, we have a transitional housing facility, in addition to some other administrative offices. We also have satellite offices in Bremerton, 2 in Bremerton, where we have WISE services. WISE are wraparound intensive services for children. This is where we may have a therapist go out to see a child in their home 2 or even 3 times a week. And provide counseling to them. We have another location on Sheridan Street where we have most of our child and family offices in Bremerton. There's a large professional building there, and we took up about half of it, but we've just rented out another 25% of the building, and we've completed construction there. So that additional 25% should be opening up any day now. So we're very happy to see that. In Poulsbo, we have a floor up in an office building off of Hostmark Street, if you're familiar with Poulsbo at all, where we provide adult services. And then down in Port Orchard, we have a brand new Bay Street location. I just toured it this week. The construction is complete and it's getting ready to be opened. We have had services down in Port Orchard, but if anybody's familiar with them, the building that we were in before was, we had long since outgrown it. So we've moved out of that, and we're very happy to be moving into our new Port Orchard location. All right, so when I speak to a group of people in the community, I realize that often the breadth of experience with mental health services spans quite a distance, from people who work in the industry to people who benefit from mental health services, from people with personal or close family and friend experience with mental illness, to people who have never even had any encounters with serious mental health issues and may not know what it's all about at all. So before I get into a lot of the services that we provide, I thought that I'd explain a little bit about what mental health treatment is. Mental health treatment can really mean anything from talk therapy, like something you may see on TV, to medication support from your primary physician, to seeing a psychiatric specialist, needing a social worker to come to your home, or even needing to stay for a while in a safe facility, of which we have several, and I can talk about a few of them. But before I get straight into the services, I think people may be interested in knowing that the fundamental principles of good mental health care, which guide our organization and the treatment we deliver. I think these principles kind of set us apart in the community from some of the other providers. I hope that's not always the case, because I think they're very good principles for providing mental health care. But I wanted to go through a few of them. And the first one is the recovery model of care. So how this differs from kind of the standard health model or medical model is it builds on it. I mean, we still have, there's still obviously it's very important for people to take their medication. It's very important for people to see their therapist. However, we find that, you know, if somebody goes, they're having some struggles, they go to their doctor, they start on some Zoloft, they leave their doctor's office and they stop taking their medication, and they go right back to the situation that they were in before, and nothing really gets accomplished. And over years of kind of doing things, doing the same thing over and over again and getting the same result, we've realized that we need to add to the process of treatment to bring people through from just treating it as a health condition to walking them through the whole recovery process. So that includes having a stable and safe place to live. You know, we overlook this a lot. There are a lot of people who are underhoused or homeless entirely who struggle, and their efforts throughout the day are focused on finding food and shelter, and their mental health needs take a back seat, and their health needs take a back seat too. So then if they're not treating their diabetes, or they're not managing their blood pressure, then they're continuing to feel sick. The worse they feel, the worse they feel emotionally, and then that all cascades. Also, helping people, walking people through and helping them develop meaningful daily activities and developing a sense of purpose. Having a sense of purpose is very important to ongoing mental health recovery. And finally, having relationships is something that all of us need. I mean, I think in the most extreme circumstances, there are certainly some individuals who struggle with very severe mental illness, and they may push back and push away relationships at every turn. And sometimes the only relationship somebody might have is that social worker who's coming to their house and interacting with them. And that's, so that's vitally important that we provide that. But even in other cases, being able to make sure that we're asking people about their relationships and their social networks, and walking them through that, walking with them through that process of developing those relationships is an important part of their ongoing recovery. So that's the recovery model. It builds on the medical model. And in addition to that, another fundamental principle is something called trauma-informed care. So I want to talk about this just a little bit too. Individual trauma results from an event or a series of events or a set of circumstances that's experienced by an individual as physically or emotionally harmful or even life-threatening, and that has lasting adverse effects on the individual's functioning in a mental, physical, social, emotional, or spiritual way. So you'll hear what I didn't say is I didn't say trauma is always a violent act. Trauma is not always sexual or physical in nature. There are certainly people who have experienced life-changing, life-altering events that have followed them through and caused problems for them for a long period of time that may not meet those criteria, although those are certainly traumatic things as well. So trauma occurs in upwards of 90% of individuals who seek help for their mental health conditions. And this is in comparison to about 50 or 60% of individuals in the general population. Obviously, many of those do end up falling into the previous category, so those are part of the 90%. But basically, most, if not all, people who need mental health treatment at some point in their lives have had a traumatic event or had some event that is affecting their mental well-being. So we realize and we recognize the widespread presence of trauma in our society. We recognize that people do recover from trauma, and we want to change the organizational practices that have historically re-traumatized people and kept them from recovery. So, you know, the patient who goes to their doctor and their doctor says, you know, you need to lose some weight, and maybe that's true, but they leave and they never go back to that doctor because the doctor didn't take some time to actually get to know that person and figure out, well, you know what, there's a number of reasons why this person may struggle with this particular medical issue, and that's not even touching the complex mental health issues that may be going on in that person's life. So when we chase away people right up front because we're not practicing trauma-informed care, that doesn't actually help our community at all. It certainly doesn't help the individual. So trauma-informed care means patient empowerment, choice, collaboration, providing a safe environment, and being able to be someone that person can trust. It's tough. It's tough when people have been through trauma. They don't trust very well. And many of us, even in this room, understand that, but it's something that we strive for. And I hope that this becomes the norm for mental health treatment going forward. Now, the third thing that I want to touch on as far as our fundamental building blocks for the way we treat and care for our clients is our peer program. Yeah, you know, in all my years of training, I heard time and time again, as people would leave, say, my inpatient unit, and they'd feel empowered and they'd feel ready to face their life struggles, they would always say, "Doc, no offense, but you know, while I really appreciated your time and the medicines really helped and all the counselors were great, but really the thing that made a difference was the people that I met here on the unit. I really felt a kinship. They understood what I was going through, and I really felt supported. And I've made some friends. I think I'm going to keep those connections going." And they really identified that their other peers in their treatment are the pivots that allow them to turn the corner and start on a new trajectory. You know, we as the providers and counselors might be able to give them some of the tools, but the people that help them to pick up those tools and motivate them to pick up those tools and use those tools are the people that they are going through treatment with. So what we've done at KMHS is we've utilized the state's peer program, and these are certified individuals who have been through mental health treatment themselves, or they're going through mental health treatment now, and they've been trained to utilize their own experiences to work with our clients who are still in the midst of their crisis. That includes parent partners, so people who have had kids with mental health issues and they know what it's like to try and raise a kid with mental health issues. They will work with our child program, and they'll work with the parents of other children with mental health issues and help walk them through that process. We have peer counselors on our inpatient units that will come and work on the inpatient unit, and they'll sit with our clients and they'll encourage them and they'll participate in the activities with them, and they'll just really help them to see how they can utilize the resources that they have available to move forward. And then we also have outpatient peer support. These are basically counselors, or they're providing a type of counseling that they're trained to provide, again, through their own experience working with our clients. Are there any questions about that? I can't see everybody.
Yeah, I was, this is Jerry. I was glad to see you have the acute adult inpatient. I understand Kitsap used to have an inpatient psychiatry through what was then Harrison's Hospitals, now St. Michael's. and that closed, I don't know how many years ago. So that's always been a problem in Kitsap. I know when I worked in mental health before I retired, that if somebody needed hospitalization, often we'd have to have them go to Seattle. So is that the acute inpatient adult place? Is that essentially inpatient? Would that kind of be essentially be for somebody who has a psychiatric crisis who needs inpatient hospitalization?
Yeah, we have 5 different 24/7 units. They range from acute inpatient to crisis to youth, to addiction counseling, and to residential support. So we have a number of different opportunities for people to get different levels of inpatient treatment that they might need. I'll try and walk through each one of them and give you a little bit more information about each one of them and kind of differentiate them out, because there's obviously some overlap there, and sometimes it becomes difficult to tell exactly what program might be right for which person, and we have people to help with that. So that's not something that anybody has to be able to figure out before they refer themselves in. But yeah, we have a number of different opportunities for 24/7 services, and grand total, when you add them all up, they total 74 beds.
Wow, that's wonderful.
At that location that I showed you on the map earlier.
Dr. Hughes, this is Naomi.
Hi, Naomi.
Hi, I was wondering, how have the inpatient units been affected by COVID?
The inpatient units have been drastically affected by COVID. We have closed our youth inpatient unit because of staffing issues, unfortunately. Now, happily, that is scheduled to reopen this May. So we're very excited to get that back open. That was really a hit on our community to have to close that program, and we regretted doing it. A couple of times we've had to close our crisis unit and our adult inpatient unit to intakes because of COVID outbreaks on the units, and those have been dealt with the Department of Health. We are on top of all of our infectious disease prevention processes. We have policies in place, but COVID is insidious, and it just slips in there, and it's hit everybody at some point or another here in the community. So we've reacted swiftly to that, but sometimes that did mean limiting services for brief periods of time. Right now, we're up and running at full capacity with everything on our inpatient services. Where it's really hit us the hardest is staffing. When our staff gets sick, they can't work, and then we do what we can to make sure that we have adequate staff to cover the units. They've really been heroic in doing so. People have been working overtime. During the snowstorm, we had a couple of people actually sleep at the agency so that they didn't have to travel back and forth. That didn't have anything to do with COVID specifically, but it really just highlights how the employees at KMHS really have embraced our mission and support us, and they're just the real heroes. I should mention that we are a nonprofit organization. We're not in this to make money. We are in this to serve the population that we are mandated to serve. So we're very focused on service.
This is Naomi again. I have one more question that kind of follows on what you just said. It seems to me like Kitsap County has a particularly robust countywide mental health. Is that true compared to other counties? Is that true, or is it this good everywhere?
It's not this good everywhere. That's a really good question. There are some Seattle, King County has a very robust system. A well-organized system. However, they have a lot of people in their system, so it may not always feel so well organized if you're in the middle of it. If you get out to some of the more outlying counties, more rural counties, you'll find lots of gaps in services through no fault of the organizations that are doing their best. but they're seeing even more staffing problems than we are, and they already have low funding and low breadth of services, so they struggle already. We're kind of, gosh, I don't know, I haven't seen every mental health system out there to compare, but I really feel like we're almost in a Goldilocks zone here. We certainly have lots of area of need and some gaps in services, but we also have resources, and we have a population that is well, in Washington or in our county, that recognizes what we do. They support us partly through certain tax initiatives and definitely grants as well. So we're very well supported.
Thank you.
Hi, my name's Jenny. I was wondering, how many prescribers do you have now? How many psychiatrists or psychiatric nurse practitioners?
Right now, we have 11 psychiatric prescribers. Not all of those are seeing people on a regular basis. Some of those are people that come in and help cover for the weekends and things of that nature. We've just hired on a new child prescriber, and we hope to have a couple more in the wings. So keep your fingers crossed for us. It's really hard to find staff for psychiatric prescribers, either psychiatrists or nurse practitioners. But we have a couple of one person coming in, one person, fingers crossed, and then one opening for the YIU that we're still trying to staff.
Well, thank you for taking the job. I mean, you have great background to run this program. And my husband and I are retired family docs. We worked for Kaiser, and you know, for many years we had a very stable psychiatric staff for probably 15, 20 years, like 4 psychiatrists. And then, you know, probably 15 years before we retired, they just kind of quit en masse. And then it was really hard to get stable. You have to have a group, and kind of take care of each other to really practice good psychiatry, because it's such a tough field. And I think even more now. But, it's great that is funding and financially, is Kitsap Mental Health doing pretty well?
We're doing quite well at the moment. We have I'm probably not the right person to speak to our funding resources exactly. There are other people who do that part of it, but we have been working with our managed care organizations. Those are things like AmeriGroup and Molina and all the providers that manage the state's Medicaid program, to meet our needs and to respond to the numbers of encounters that we actually provide. And we're working to try and become what's called a CCBHC, or a Certified Community Behavioral, I'm going to get it wrong, Healthcare Center or something along those lines. Sorry if I got the acronym wrong, but it's what it does is, if we meet these basic criteria, then we're able to submit for reimbursement in a different way, that the state then recognizes that we're providing exceptional service over and above, and they reimburse us accordingly. A lot of states have moved towards this direction. The federal government is really pushing for states to adopt this model. Washington hasn't adopted it yet, but we're going ahead and moving forward to become a CCBHC program in anticipation of Washington making that move, and hopefully they will. Even if they don't, it's just a really good practice for us. It's focused. The CCBHC is focused on integrative care, efficient care, being able to demonstrate different levels of care that we're providing. demonstrating equity, uniformity in practice, even getting into things like our translating services, just all the different aspects that make sure we're reaching the people that we're reaching. The most important part of it is doing a community survey and finding out what Kitsap County itself expects from us. What does Kitsap County expect from a mental health treatment center, and are we providing those things? So that's part of our CCBHC direction. We're excited.
So are you working with the local police or anything about psychiatric, emergencies and stuff?
Wow, that's a really great question. Actually, I can speak to that. Let me move forward on my presentation real quick, and I have a slide on that one, and I think that'll explain a little bit more there. So what I wanted to do is I wanted to kind of walk through some of the services that we provide, but instead of just doing kind of a dry list of these are all the different things, I thought it would be fun to just make up a story. I used my own name so that we can keep this as ambiguous as possible, and the photograph is a stock photo. It's not a real person. So Jay is a 55-year-old truck driver who struggled with emotional issues since his own rough childhood. He's come to Kitsap County from the Tri-Cities area to stay with his sister after losing his job due to COVID-19. His depression has been affected by his loss of income, estrangement from his own family, and he's found himself taking solace in the escape he feels when he overuses the pain pills that he got for his back. But of course, he lost his doctor in the move, and now he's run out of medication. So he's been struggling with withdrawal, in addition to the pain, in addition to his clinical depression, and now he's hopeless. Jay is wondering why he's even still alive when a friend that he meets sells him a fentanyl patch for $40. I'm not going to go into the next steps. You can kind of imagine that this could go any one of a number of different ways, and some of them are more vivid than others. So I'll leave that to your imagination. But let's just say that Jay gets in touch with our crisis services here, and this is an answer to your question of how do we participate and work with the different law enforcement and emergency services. We have at Kitsap County, we have a crisis line called the Volunteers of America. Well, they're the organization that contracts to serve our crisis line. So this is important. If you or someone you know is experiencing a crisis, suicidality, addiction, or a deteriorating mental health condition, this is the number you call. It's 1-888-910-0416. Also, you can go online to iamhurting.org and chat with one of their counselors. What will happen if you do this is the telephone counselor will determine whether or not life or safety may be at stake. And then they will contact, if that's the case, they'll either refer you to whatever outpatient services you might need, or they'll contact the designated crisis responder. Every county has designated crisis responders, and in Kitsap County, they work for Kitsap Mental Health Services. They are KMHS employees, and they will go out to the individual wherever they are in the county, and they'll assess them for services. The DCR may decide that this individual needs to be in an inpatient service, or they might decide that they need to be plugged in with outpatient services, or they might decide that they would be good candidates for our voluntary Kitsap County Crisis Triage Unit. They might put this person in their car. They might call an ambulance. They might call a cab and have that person transported to the crisis triage unit, or they might call law enforcement. Say if this individual is psychotic and behaving very erratically and seems to be a danger to themselves or to other people, they may call law enforcement, and hopefully law enforcement will help to bring that person to an emergency room where they can be seen and assessed. So we work very, very closely with all of our law enforcement agencies. That includes the Bremerton, Poulsbo Police Departments, the Kitsap County Sheriff's Department, and our different tribal police forces. We actually meet every week. Our crisis, the director of these crisis responders meets with the different law enforcement agencies where we can discuss any particular cases, anything brewing. Oftentimes there are cases where people are aware that something is developing, but it hasn't quite reached a point where anybody has the ability to intervene yet, but they can talk about this, they can make a plan. So not only do we work well with them, we actually meet with them once a week in person. Is that helpful?
Oh, yes, Barry, that's amazing that you're meeting weekly.
Yeah, it's a really good relationship, and it's been developing more and more. I think, you know, in anytime you're getting different organizations to cooperate with each other, there's always that initial element of, well, you know, how much more work is this going to be for me? But having these regular meetings really just helps us all to see, you know, we're all human beings, we're all on the same page. We all want what's best for our community, and this can be, you know, this can be fun. It can be fun to work together. It can be very rewarding to figure out how we can use our resources and cooperate and make things happen for the benefit of our clients.
Dr. Hughes, Naomi again. Is there a program where people go into the local jails from KMHS?
So I'm not going to be the best expert on exactly what we're doing in the jail system. We used to have somebody who went into the jails, but right now the jail has their own mental health services that they contract with a nurse practitioner who is a psychiatric specialist. Those are issues that sometimes get bogged down in contracts. I know what we do have is we have a liaison that helps to make sure that people who are leaving the jails get plugged into mental health services. We monitor the jails so that anytime people who are enrolled in our services are admitted to the jails, we are able to follow up with them. And then we make sure that they don't get lost to follow up. We make sure that they get their medication while they're in jail. Because people aren't often in jail for very long, just for brief periods of time, but historically that's a time when people get lost to services. They go in for 45 days, they run out of their medication, they get worse, they come back out of jail, and then they get lost to services. So we make sure that doesn't happen. We're kind of constantly reevaluating our contracts with the jail to figure out what we can provide, what is being provided by other agencies. Another area that we're always monitoring is the mental health court, where people are diverted from criminal court, and it's recognized, the court recognizes that they have a mental illness or they have an addiction issue, and so they're court ordered into certain types of treatment. So we pay attention to that as well. Yes, Jill?
Oh, hi. What are your suggestions for making the system better? You know, we hear, first of all, it sounds like a lot of places in the country are not as enlightened as your group. And we hear about jails and even the police with best intentions, not arresting mentally ill people correctly. But what are some of your suggestions for other venues, for other people?
Yeah, let me tell you, it goes back and forth, and that's a question that I think if anybody knew the answer to, it would be a great thing. I certainly have some of my own opinions. One thing that's going on in your legislature right now in Washington that you should be aware of is something called House Bill 1310, and that is a bill that came out in response to all the issues that were going on, really sparked with primarily by the George Floyd murder. However, there's clearly that's not the only event, and there were many other things leading up to that. But the Washington legislature decided that they were going to make it a law that the police couldn't lay hands on people or couldn't offer force in compelling people to comply with things unless a crime was being committed. And unfortunately, as often gets the case, and here's where my opinion comes in, and I'm just going to say my opinion is not that of KMHS. Let me put a little distance there. But unfortunately, what happens a lot of times is that mental health care gets forgotten or gets put on the back burner. And one of the unfortunate consequences of this is that police all over the state of Washington became very uneasy about using force with mental health persons. Now that's a healthy thing. On you might say, well, that's a good thing, right? We don't want police to use force with them, and usually that's true. But what we want is for them to use appropriate force. We don't want them to assume that somebody with a mental health issue is committing a crime and then use excessive force. However, when somebody does have a mental health problem, we want the police to be able to help us to move that person to a safe environment. And so right now in the legislature, they're rewording this bill because we had an almost immediate effect of being unable to bring people into the hospital involuntarily who were experiencing tremendous pain and suffering through their psychosis, or who were even presenting a danger to themselves or others. So they're rewording the bill in the House right now, and there's a couple of different bills that are in play to try and reword this and make sure that the police understand that they can use appropriate force when necessary. But it's just such a balance. How do you create a policy for a policeman to say this is what you can do, this is what you can't do, when they're in the middle of a situation and they may feel that their life is in danger? To say don't do anything hurts the mentally ill person who is now not going to get treatment. To not put any rules in place then potentially leaves that policeman without a lot of guidance and leaves openings for them to inadvertently hurt the person. So it's a tough balance. There are a lot of people with greater minds than mine that are working on it. But the police and force issue is one of those things that we need to get better. The other thing that I'd say we need to get better is our crisis services themselves. Right now we have very specific crisis services. I've mentioned the DCRs. They're wonderful people. They'll go out, they'll de-escalate a case, they'll get involved with the person no matter what their mental health problem is, and then they'll try and make some referrals, but the follow-up is often just left to the individual or the individual's family, and there's not a lot of good handoffs that occur in every case, and so we need to get better at that. And our region is working on that. Our healthcare authority and our regional healthcare authority, the Salish region, is working on trying to establish crisis teams that go out, not just crisis responders, but crisis teams that go out and they stay involved in the person's crisis until the crisis is abated or until the person gets plugged into services. So those are things that are in the works.
Dr. Hughes, we have a question in the chat box from Marty and Bill. It says, are you pro or con on HB 13107?
1310.
Okay.
Yes, the House Bill 1310. I can only speak to its effect on the mental health system, and it has hurt the mental health system. It was not written with the mental health system in mind. It was written with a lot of other social ills in mind that we want to correct. So whether or not the House bill itself has helped or not with those, I really don't have any expertise to speak to that. But as far as the mental health system is concerned, it has hurt the mental health system. It needs to be updated, and it is in the process of being updated. I think everybody recognizes that.
Yeah. You know, I'll admit my ignorance here, but could you briefly review what 1310 does? And
yes, House Bill 1310 is the bill that requires police not to use any force unless a crime is being committed. That's a very brief summary of the bill, and it gets into a lot more detail than that. But the reason it's hurt the mental health system is because when a person, say this is a client that we know well, they've been in our system, in our services for many years. The doctors know them, the counselors know them. Everybody knows that this person is ratcheting up to a point that their psychosis is starting to interfere with their ability to perceive reality. And everybody knows, because it's happened time and time again, that this person is going to get to a point where they're either a danger to themselves or a danger to other people, or they already have gotten to that point. And the DCR may determine that imminently we think this person's going to be a danger within the next 24 hours. And they can get a judge to order a pickup order. And the judge will say, yes, this person needs to be committed, pick up this person, bring them into the hospital. And House Bill 1310 requires the police to refuse to pick the person up because they're not in the midst of committing a crime. So what happens is we have to wait for that person to commit a crime. And then the police go pick them up, they bring them to the hospital, and then they have a criminal record. And that's just really, really unfortunate, when we could have stopped it 24 hours earlier. And we would have done that last year or the year before, or before this House bill came out. Again, I don't want to be too negative about it, because everybody recognizes the unintended consequences of things like that. And I think everybody recognizes the good intentions of the bill. So, you know, I want to be very, very cautious about that, and recognize that our legislators they're all very well intentioned, and they have the needs of the Washingtonians at heart, but this needs to be corrected.
Can I do another story?
Sure.
I mean, you know, can we, it's almost like, could we sue the legislatures for incompetence? Because I'm not kidding, because it's totally incompetent. If a doctor did made the same errors, said, okay, I'm really going to try very, very hard to take your appendix out, but then they go through the heart to get at the appendix, something like that. That's sort of like, they would be sued. That would be incompetence. This is truly an incompetency. And I think that they don't study the bills. They just pass whatever seems appropriate at the time. I think a lot of our legislators don't even read the bills in detail, and they're not familiar with what they have to do. And then they're told by their party what to do, because it seems still, you know, there's a lot of being told how to vote. They don't actually read it. I think that would be quite, to hold, you're very nice to our politicians, but oh, they tried hard. I'll bet they didn't try hard. I don't think they try that hard. Anyway, I think you could hold them accountable, and some of the mental health people could say no. And I don't know why the mental health people weren't asked about this prior. In other words, why did they pass it without touching bases with everybody who's going to be involved?
Yeah, I know the mental health people have been the mental health people, namely our CEO, and who is the president of the National Council. Well, he's the president of some facet of the National Council for Community Mental Health Agencies, and several other representatives of community mental health have been consulted. However, even now, with some of the wording as they're going through and they're making changes to the bills, they're focusing a lot more on the, you may have seen in the news, there's some problems with people who are stealing catalytic converters, and the police can't hold them for questioning. If they can't, even if they have a suspicion, they have to just let the person walk away if the person doesn't want to stick around and answer questions. And so the bill is focusing on a lot of other aspects of the language that have caused problems that I'm not an expert in. I just hope that in the process of making those changes, they are paying attention to our input, and they make those changes applicable to mental health care as well. We'll see. We'll see as they move forward on that.
Barbara, you have your hand raised?
Yes, I did. Just like Jill, I'm a little shocked that we have to wait for a crime to be committed before people who need help can be given it. And sorry for thinking like a lawyer, but the best thing you can do is practice preventative law and set things up so that possibilities like this don't happen. This seems very negligent to me, and it's probably going to take some very serious damage to someone, possibly death, before somebody gets sued, and that's what's going to make them change it.
Yeah, anybody else have any thoughts on that?
So the bill has actually been passed already?
House Bill 1310 is in effect right now.
Oh my
There are
gosh.
2 bills in committee that are being discussed to revamp the wording to correct the issues. Now, I will say that we do still, the police, at least in our county, have recognized that this has led to some unintended consequences, and they of late have been working very closely with our DCRs, have been going out with the DCRs and providing the backup that they need. So the DCRs are quite happy with the police response lately. We just want to make sure that the police have the legal backing to be able to do what they need to do.
There are other models for this problem. In other places, Las Vegas is the one that I know well because I have a friend who works in it. She's a clinical social worker, and she goes out with the police and she sits with the scanner. They secure the scene, and then she decides, she runs the scene, kind of. She gets to decide if somebody needs mental health services or if it's a law enforcement issue. And they don't decide that, she does. And it seems like she does a lot of good. It doesn't help with the transporting mentally ill people who have a crisis, but people who are called for a general committing a crime or just a disruption, it helps those people a lot.
That sounds very similar to the way things actually work on the ground here in Kitsap.
Nice.
Yeah, it does work out quite well. It does come down to whether or not that person's going to be able to be transported. Because if they're dangerous, we certainly don't want our DCR to put them in their car. We don't want to call a cab for them. We need the police to do that transporting, and that's where this bill comes into play. But as far as the relationship that we have, working with the police, meeting with them every week, keep maintaining those good relationships, that has really worked in our favor in this county, and so the police have been able to go out and make sure that our DCRs are safe. And so with your, Naomi, with your example, I don't know if you have a like more of a crisis model where the social worker goes out with the police. In Kitsap County, the DCR is a separate individual. The police would meet them there. Those get to be semantic things at some point, but but it does sound very similar.
Okay.
It sounds wonderful. It sounds like you're the kind of person who's read the book Being Mortal by Atul Gawande, and
haven't read
really
that.
listens to the person. You start with caring, compassion in your character, and capable. This has been totally enlightening. But I haven't heard, or we haven't heard, a single thing about NAMI Kitsap families or about ombuds. And it seems to me, since NAMI Kitsap's going to go down there with NAMI in several weeks and going to be spending a whole day on these issues, I'd like to hear what, I know you've only been here a year, but what is your present way of operating from your standpoint with the families in NAMI and with ombuds? Where do we come in and work together so that we can get things like 1310 corrected?
That's a good question, and I think that there are a couple of things that I can answer about that. Number one, I'm familiar with NAMI just from my entire career of being a psychiatrist, and I can't say enough good things about the organization. It's just been an amazing way to get the issues of mental health care struggles with out into the public eye. Not to mention the amazing support that they provide to both their members, the family members of people who are struggling, and also to just supporting the families themselves. So NAMI is an amazing organization. As far as the ombudsman, I'm not sure exactly who you're referring to. We do have a state ombudsman that we work with at Kitsap Mental Health Services. Usually that gets engaged when there's a conflict between one of our clients that doesn't feel they're receiving the care that they need to be receiving from us, which does happen from time to time, and we work with those clients directly and try and serve them as best we can. And if we can't resolve the conflict, whatever it may be, then the state's ombudsman steps in, and we work with the state's ombudsman to find some resolution and cooperative solution to that.
Dr. J, this is nothing like this. This is something that they had a couple of people. They were stationed in the dispute resolving center in Silverdale, and they went out and they were ombuds to stand with the people, whatever the crisis was, for the person. And it sounds like what you've done, and this sounds good. You've got the crisis people who are skilled, as you described them. It sounds like they are the ones. They're certainly going to look out for the individuals, just as a matter of the golden rule, how they'd like to be if they were on the other side of it. It sounds like this ombuds thing is sort of been flushed. As far as NAMI is concerned, as far as NAMI is concerned, you've got Bill and Marty in on this conversation. Perhaps I don't know if Larry Brixis is still the president now. I think somebody else takes, but people like Dave Keel. You've got a bunch of families committed and talented out there that can be part of this total process. So
that's a really good point. And again, back to the ombuds people that you're referring to, I may not know everything that even happens within the organization. It's very likely that the crisis responders are already involved with those individuals. However, I will say that as we collected more information about the effect of the House Bill 1310 and how that was affecting our clients, it caught the attention of our Salish behavioral health region. And now the healthcare authority, the state's healthcare authority, has been actively collecting information on individual examples of people who may have been affected by this. And so there are a lot of people involved in organizing the data collection that will be necessary to get that fixed. I would be very surprised if NAMI wasn't in touch with the healthcare authority already and part of that whole process, but I really can't speak to whether or not or to what extent that's happening. Hiroko, I saw you had your hand up. I think you may be muted. I can't hear you.
Yeah, Hiroko, you can unmute yourself if you have a question. It's on the lower left on my computer screen to unmute. Oh yeah, you're still muted, Hiroko.
Can you hear me?
Okay.
Oh, we got it.
Okay,
Okay,
good.
okay. The police involvement in Seattle are changing. I'm a retired social worker, and now the police called, and sometimes I don't think it's enough, but the social worker involved to help, to support. So things are changing in Seattle a little bit. It's not enough. But my question is, the mental health, your outpatient is the people who are inpatient and they become outpatient, or just not seriously mental health issue, but still get the mental health service?
Yes, that's a great question.
Yeah, because I worked as a domestic violence advocate, and they have a lot of mental health issues because of youth, and it's very difficult to get mental health because it's very expensive. If you use individual, you get a therapist, they cannot afford. So it's a big issue when someone left the abuser, and but still lots of trauma. So is that a medic? If it's seriously ill, medic, and if poor, Medicaid paid, right?
So if people have their own private health insurance, then they are free to utilize our crisis services. Anybody can call the crisis line, anybody can get crisis services, anybody can come to our crisis triage center for 3 to 5 days and have a voluntary crisis stay if they need it. However, if they have private insurance, then we try and help them. They can still come in for an assessment. We're happy to provide that free of charge. But then we try and help them, we navigate them to the resources that they have through their own insurance company. If somebody has Medicaid or is unfunded altogether, they can also come into our outpatient services and seek treatment with us. And if they're eligible, we'll help navigate them onto Medicaid. Obviously, if they're already on Medicaid, then that's not a problem. They're already in the system. If somebody wants to come into our services for outpatient treatment, and that they'll come into our outpatient department, they'll be assigned a team, they'll have a therapist, they'll have a case manager. If they need it, they'll have medication management services, and they can achieve that just by walking in. They don't even need an appointment. Obviously, you can call for an appointment and probably would be helpful for us, but it's not required. And we'll take anybody who walks through the door. If they walk through the door and we find out that they have Kaiser, for instance, then we'll help them. We'll do the assessment. We'll find out what their immediate needs are. They might need crisis services, in which case we'll help get them into our crisis triage center. even if they have Kaiser, that's perfectly fine. However, if they don't need crisis services and we've determined that they need some outpatient services, we'll help navigate them to their resources.
Okay.
So I just wanted to show a couple. I know we're kind of running a little short on time, and I don't want to. I don't feel like I have to go through all of my slides, but there were just a couple of things that I wanted to share with you from a data standpoint. I didn't want to bog this talk down in data, but these were a couple of things that just really stood out to me to really help me to understand conceptually how much the pandemic has affected mental health in Kitsap County, or in Washington, in the United States, really. And this first chart that I wanted to show and share with you is our unemployment insurance claims for the first part of 2020. There's a line down near the bottom that shows the peak unemployment claims during our recession of 2008 and 2009. And you can see right during March, right between the time that Boeing shut down and before the government shut down the restaurants, we just started laying people off in droves. And the sheer magnitude of the number of unemployment claims and how far above even the recession, the past recession, it went, just astounded me. Obviously, these stressors affect people from a mental health issue, so that's why I wanted to point this out. And the next chart that I have is sadly the number of drug overdose deaths in Washington state. We've had an opiate crisis going on in Washington state since the 90s. We've had the number of opiate deaths rising. This is the number of all types of drugs, but opiates make up the vast majority of them. Right around from 2015 or so, for about 5 years, we had a somewhat stable level, but you can see when COVID-19 hit that our opiate death rate has just been steadily climbing. It doesn't show any sign of slowing down. I don't have the statistics up to the minute, but up to about halfway through 2021, they were exceeding even 2020. So this is, I can't say for sure that this is because of the pandemic, but you can look at the chart and draw your own conclusions. I think that my personal opinion is that the pandemic has had just a tremendous effect on the state of mental health in our community. So I wanted to share those two with you just because the obviousness of the graphs themselves impresses me in a very sad way. So beyond that, I have a few more slides about the services that we do provide. I think a lot of you probably, it sounds like you probably already understand them quite well. So maybe it's not necessary that I go through all of them. But I'll just go ahead and find out if there are any more questions.
Yeah. I just want to quickly say, this is Jerry. We ending at 1 is not rigid. Sometimes we go to 1:15. So, I guess what I'm saying is don't feel like we have to rigidly stop it. Some of you may need to leave, I realize, but we don't have to rigidly consider 1 p.m. a rigid.
Oh yeah, and I'm happy to walk through the rest of my slides if you'd like. That's fine too.
Okay.
What would everybody like me to do?
Yes, keep going.
Keep going?
Yes, please.
Yeah.
Keep going. That'd be great.
Okay, sure.
Please,
All right.
if you don't mind.
Yes.
Let me check my notes here. Okay, I don't think I have a whole lot more notes. I think that they're just some slides that I want to walk through. Going back to our, just to show you the services that we do provide, going back to our main campus here, I'll kind of focus in on the Crisis Triage Center this building up top. This is our crisis triage center and our addiction residential rehab called Pacific Hope and Recovery. So in my story about Jay, somehow Jay manages to get referred into the crisis triage center, and this is a 16-bed unit. It is voluntary, completely voluntary. It's open to any resident from Kitsap County, regardless of their ability to pay, their insurance, whether they're on Medicaid or not. We accept referrals from the emergency department, from law enforcement, from Indian Health Services, from outside hospitals, and of course, from our own designated crisis responders. So if somebody feels that they're in crisis, then they call the number that I gave you. They say, I'd like to go stay at the crisis triage center. The designated crisis responder does an assessment, determines that that's appropriate, and they go ahead and bring that person to the unit. So we treat people with any sort of crisis, any sort of mental health crisis. That's depression, severe anxiety. They may be confused or have disorganized thoughts. They could have problems with self-care, addictions. They could be having conflicts with their primary support. There's any number of things that somebody might feel they're in crisis. I think the important thing to point out is that the crisis is not something that we, for the most part, not something that we determine whether or not it's a crisis, but something that the client determines whether or not they're in crisis and if they need the support. We provide some validation. We provide great food. We have an amazing chef at who serves our entire campus. There's camaraderie, there's warmth, there's safety, there's counseling, there's substance abuse evaluations, there's on-site nursing care. A lot of people come in with medical needs, medical issues, skin breakdowns, uncontrolled diabetes, things where they've neglected their self-care, or they're just to a point where they're maybe so depressed that they can't, they're not taking good responsibility for their own self-care. We can help with all of those things. Now, in my story, Jay he comes in and he goes to the crisis triage center, and he's there for 3 to 5 days, and he's had a chance to participate in his stabilization and his decision-making process. And he, along with the counselors, collectively decide, you know what, Jay, you would do great in a 4 to 5 week placement where you can have some reliable, caring, non-judgmental, certified substance abuse counseling. You can spend 5 hours a day in these interesting and fun groups with other people who are going through what you're going through. You can develop some really meaningful relationships. You can take smoke breaks as you need to. You can really focus on your issues and your addictions. And we have a 16-bed residential facility in that same building. It's literally just right down the hall from the crisis triage center where Jay stayed initially. So Jay made some great friends in Pacific Hope and Recovery, but he's still struggling. And as we all know, recovery doesn't happen overnight, and Jay needs some time. Maybe Jay's sister says, you know what, you're not coming back to live with me. This was a bad idea. So now he's kind of burned that bridge, and she was his local support, and he needs a safe place to practice sobriety and practice his treatment compliance. So this is where we're going to zoom back out and focus in again on our transitional residential unit that's down here at the bottom. This is called Keller House. Here's some photographs of it from different angles. Keller House provides it also has 16 beds. These are residential living for people who need additional support. They have private rooms. They have freedom of movement. They can come and go. It's not a locked unit. It is voluntary. They have all the comforts of home. They might live there for 2 to 3 months while transitioning to independent living. They're provided substance abuse counseling, and if needed, this is in answer to a question earlier. If needed, that at this point they might be enrolled in outpatient services. So medication management, supervision, and outpatient counseling might be provided at this point. And we also have vocational support services. We do have vocational workers at KMHS where people come and participate in a program where they need some additional support to be able to perform their job. And we have supported employment in the community. I don't know how active this program is right at this moment, because we did have some staffing issues due to COVID, but we hope to get that up and running in full pretty soon. And this is where we help people, we interact with the employers, and we help people to get plugged into full-time employment in the community, full-time or part-time employment. And if they're struggling for whatever reason, the employer can talk to us. There's a case manager that can help navigate that situation and keep people employed. So I'm zooming back out here to zoom in again on this building in the middle, what we call Building B. Down here in the bottom of that building is the youth inpatient unit, and in the top of that building is the acute adult unit. Our adult inpatient unit is a 16-bed psychiatric intensive care unit. We provide inpatient services. Most of those people are committed. A few may be voluntary. We have people who are well known to our services, and they trust us. They understand that if they're going through a psychotic illness or a psychotic break or severe suicidality, they can check into our services. But mostly when we're talking about the people that a judge has ordered a pickup order for, and the police have gone out and fingers crossed the police decided, yes, this is somebody we need to actually go ahead and pick up, or they can convince them to get in an ambulance and go to the emergency room, then they'll come onto this unit. They'll stay anywhere from 14 days for an initial commitment to 90 days or 180 days for long-term commitments. We do have a court right there in the building that provides services to help people to be able to avail themselves of our treatment without having to go down to Port Orchard. And then in May, we're going to be opening up our youth inpatient unit again. We're very excited about this, and I think this is going to be really great for the community. This will be 10 beds. We'll take people generally ages 10 to 17. Doesn't mean we won't take people younger than that, depending on the circumstances. And we're in the process of getting that all finished right now. The construction is underway. The unit is scheduled to be done with construction in March, and then we'll have a few state approvals that we have to go through to get open. So I zoomed back out and to show you the campus again, and then this other building is where we have our outpatient services. I think I might have mentioned that already. We have outpatient, we have a day school and a pharmacy, and Peninsula Community Health Services is a large provider in Kitsap County. They actually come and they staff our primary care office to provide primary care services to our clients. So our outpatient services, every client that comes into one of our outpatient services is assigned a team. That team includes a mental health counselor. It might include medication management. They definitely have social services, family support. They may have addiction specialists assigned to them if they need it. And there are other mental health specialists and peers that are part of that team as well. As I mentioned, the on-site pharmacy and the primary care is available to people in our outpatient services. All right, so this is Jay's story. He gets set up with the outpatient therapist, and he has a team of people to make sure he has all the resources that he needs. He now follows up regularly with his medication provider. He has pharmacy access right on campus. He started addressing his needs through his new primary care provider on site. He's attending substance abuse groups, and he's positive about his new vocational prospects. So we feel like Jay is entering recovery at this point. And then here's some of the things that I didn't get to. We did talk about some jail liaison services. We also have a PACT team. I do want to mention this. PACT is our assertive care outreach team. These are people who go out into the community. We have nurses and mental health providers who will see people in their homes or on the streets or wherever they happen to be, people who would otherwise not be able to make it in for services. We can go out and check labs wherever they happen to be. We can go out and give them an injection if that's what's needed. The person's participating voluntarily, but often they're on what's called a least restrictive order. That's where the judge has said that, you know, you're okay to leave the hospital, you're doing great, but you have to stay on your medicines. And if you don't stay on your medicines, then you'll have to come back in the hospital. And so people are generally pretty agreeable to staying on those orders. We have a New Journeys team. This is a team that treats first episode psychosis. I don't know if anybody, I hope, but it's very possible that I don't know if anyone in this room has had to deal with first episode psychosis, but it can be very, very traumatic and devastating for families who are going through the experience of having a child or a young person, a young adult who's experiencing a first psychotic break. They often have never had experience with the mental health system before. They don't understand what's going on. There's just so much to learn, and having a team of people who understand it and are dedicated to working with that person is very helpful. Oh, and I'm glad I went through, because I did want to tell you about Pendleton Place. Has anybody heard of Pendleton Place? Okay. Pendleton Place is our homeless project. This is a current picture, so it's in the process of being finished right now. It's on Kitsap Way. It's just north of the Auto Center. This is 72 beds. It's basically built like a hotel. It's very nice. 72 beds, and it is specifically for people who are currently homeless in Bremerton who have a mental health diagnosis. So we will be providing homes, permanent supported housing to 72 people who are currently homeless in Bremerton. It has been a real, just a wonderful development for the community.
Yes. Yes.
This is these are some pictures of the construction. This is the great room where they could have community activities. This is what an apartment will look like. You can see it's a standard, fairly nice apartment, good, clean, safe appliances, lots of light, spacious bathrooms, ADA compliant. And I just wanted to share that with everybody as well, because I think that's going to be a really big benefit to Kitsap County.
Was this funded through the Kitsap Housing Authority?
It was the 1/10 of 1%. There's a block grant. There was so many different things. Again, the money is not my specialty, but there were a lot of people. Bremerton Housing Authority, a lot of people came together to make this work.
Okay, thank you.
That is wonderful.
Yeah.
Yeah.
Very thankful, because many people who are seriously mental health issues cannot keep a job and become homeless and getting worse. So it's so wonderful. Thank you.
Yes.
That it fits with our core principles of providing services under a recovery model.
Yeah.
So having a house is the first thing.
Yes.
Before we do anything else, we've got to get somebody a house,
Yes.
Because it doesn't matter what we do, if they don't have a house, all of our efforts are going to be in vain. I'm not saying that is across the board. Obviously, there are exceptions to the rule, but that's
Wonderful.
Yeah. Somebody raise their hand.
I didn't raise my hand, but I do have a question again.
Okay.
Where would the perinatal population fit into this? Is there something in the new journeys for the first episode of psychosis? If that's the issue?
By perinatal, you mean people who are pregnant and experiencing psychosis, or do you mean?
Pregnant and or postpartum?
Yeah, we don't have any specialists specifically for perinatal care. I would love to have that. That's not an easy. That's not an easy, yes, right. That's not an easy call. Yes, actually, I think we need to talk more about that. The place where a perinatal where the perinatal needs are, well, I don't know that Peninsula Community Health has any specific expertise in that right now either. I know the University of Washington has perinatal specialists, and they can. If I had perinatal mental health issues, that's where I would turn.
Okay, great, thanks.
Okay.
I did want to mention that, you know, KMHS is not the only place to get mental health care in Kitsap County. Obviously, any primary care provider, that's the primary care providers carry the biggest lift when it comes to helping people with mental health care. That's where we all turn first if we're experiencing some problems. And often our primary care providers become the only people that we see for mental health care. And I want to call out specifically CHI Franciscan, which I believe is the parent company of St. Michael's. They have a family medicine residency here in town, and Peninsula Community Health Service also. Both of them work closely with us to provide integrated primary care. Also, we have plenty of certified psychiatric providers in the area and on Bainbridge. We have counselors, therapists, naturopathic medicine doctors. All of these people become the people that carry the bulk of mental health care in any community. For our area, we have multiple Medicaid and non-Medicaid psychiatric hospital facilities in Tacoma, Edmonds, Marysville, and then the Seattle, Kirkland, Bellevue area. If we happen to be full, or there is somebody who is we're not able to take care of, then we may refer people out to one of these facilities. And then I'd be remiss if I didn't acknowledge St. Michael's Emergency Room in Silverdale. They just are functioning at maximum capacity, over capacity, since the whole COVID thing has been going on, and they've been amazing. They deal with a lot of mental health issues and without often having the expertise within their organization to do so. So they really bend over backwards for us, and we appreciate them. Somebody raise their hand?
I don't see anybody.
Okay. I mentioned at the beginning a couple of different treatments for depression that we don't provide at KMHS, but a lot of people have questions about them because they are either new, novel, or interesting. And those are transcranial magnetic stimulation, esketamine therapy, and ECT, or electroconvulsive therapy. So if you've heard anything about any of these treatments, a lot of people come with questions about them. We don't offer any of these specifically at KMHS. Transcranial magnetic stimulation is offered at a couple of different clinics in Poulsbo, my wife's clinic being one of them. Esketamine therapy is something that a lot of people have heard about, and that's where you have a nasal spray that's administered in the doctor's office. I know there are a number of primary care doctors around the area that are doing this, and it's also offered in Seattle. And then ECT, or electroconvulsive therapy, you may have heard of this as a shock therapy. Certainly, it has been around for a long time. However, it has developed into a very a clean and precise treatment that's incredibly effective for depression, and usually something that we do when people are struggling with very severe depression, and that's offered at the University of Washington and Overlake Hospital, and I believe Swedish. All right, and then I wanted to leave with the crisis information again. Also, our Kitsap Mental Health Services phone number for anybody who's Medicaid eligible or uninsured. And then I wanted to let everybody know that there will be a national crisis line coming soon. I don't know if you've heard about it, but you know, we have 911. If you have an emergency, you can call 911. But a lot of times with mental health crises, people aren't sure. Is this really an emergency? Is it not? Do I call 911? They get scared. Pretty soon we're going to have a crisis line that'll be 988. Hopefully by the mid 2022 that will be available. That's when it was scheduled to be coming online. So keep an eye out for that. Don't call it yet because it doesn't work. But pretty soon we'll have a 988 national crisis line for mental health crises.
Who is
Very
answering?
excited about that.
Who is answering this line?
Say that again.
Who is answering this line?
This is the federal government.
Okay.
No. If I called this number.
Oh, who is answering it?
Yeah.
I don't have that information. I would imagine that the like 911, it automatically dispatches, or it automatically sends you to a local dispatcher, and so I would imagine they'll have, you know, any number of different organizations that participate in answering the line depending on where you're calling from. But I don't know.
Is that the police or? Is that the police or mental health professional?
It's almost certainly not the police.
Okay.
Wow.
I just want to make sure.
Wow. Thank you so much, Dr. Hughes. I'll kind of echo what Bill said. I'm just so impressed by the care and the kindness and in Kitsap Mental Health and yourself, and the holistic approach, housing and socialization and Medicaid. This just seems. I'm so glad you're here. I'm so glad Kitsap Mental Health is here.
Thank you. Thank you.
Oh, I think we have a lot of really good things on the horizon. Yes, there are some hiccups, and you know, I understand some of the frustration with the legislature, but it just seems to me that for the most part, people have, well, at least the people that I'm immediately exposed to have their hearts in the right places. So you're right. There could certainly be some other agents out there that we want to be cautious of. But I've been very encouraged just in the year that I've been involved in this process with KMHS, and I love seeing the fact that everybody who comes to work, they come with this idea in mind of there's a purpose, there's a reason that we're here, and it's to serve our county.
Yeah.
Thank you very much.
Very.
Well, thank you for the presentation.
Oh, you're welcome.
And thank you for good
Thank you
work.
for your work.
Thank you for the presentation.
Yes,
You're very
thank you
welcome.
for
Yes.
your
No,
work, and thank you for the presentation. It was very good.
You're
Yes.
welcome. Thank you for letting me present to you today.
Thank you.
Very thorough. Yeah.
This has been wonderful and builds so much hope. I hope that you stick around for a while. Don't run away from us, that your leadership will lead to collaboration with these folks and all the people who work with in this healing arts.
Yeah.
Thank you for that sentiment. That's very nice.
Yeah. Well, so
I'm leaving now. Thank you, everybody. Thank you.
yes. Yes.
I'll stick
Okay.
around, and if anybody has any further questions, I'm here until Jerry shuts us off.
No, I'm not going to. As long as people have some important questions, I'm not going to shut anybody off.
I've got a question for you. And I'm wondering if there's any new treatments for psychosis, schizophrenia, kind of in the pipeline, kind of that.
Yeah, a good question. There are a couple of new medications that have come out recently. Quite honestly, they perform about as well as some of the other ones. You know, one of the problems that we have in our community, in the psychiatric communities, we underutilize a medicine called Clozaril, which is very effective for psychosis. However, it requires weekly blood draws, and that's a very difficult thing to get people to buy into. So if we had some system to help make that more of a normal thing, then I think that would be really beneficial. But that's a direction we could go, just as far as utilizing some of the things that we already have. The research for schizophrenia is always ongoing, but it's a frustrating illness.
I have a question. You talked about, helping people find a purpose, which I think is really important. And, I think probably in younger people who are having mental health issues, that's one of the biggest problems right now. Do you guys have a way you try to help them with that?
Yeah, and that's a very vague goal, isn't it?
Yeah.
It's hard to quantify that. However, it's important, I think, to keep it on the forefront of people's minds. So while they're offering their treatment, they can realize that that's something that's necessary. And if they're not achieving it, whatever it might look like in that individual, then they're probably not achieving recovery. We are looking to expand into, if possible, opening up something called a clubhouse or a treatment center where people can come and participate in activities, learning activities, and develop relationships with each other, and have a place to go, have a group of people that expects them to be there, and help provide purpose in that way. When it comes to just kind of your standard outpatient, maybe like this guy Jay, who wants to get back into truck driving or something, and wants to rebuild his family. That's then deciding on what purpose is becomes a lot more individual, and that's, I think, where having those peers involved in the process is really important to just help be there with somebody, be able to say, and this is what I went through, and this is how I found that purpose in my life. That's something that it's really tough for a therapist to impart to someone else.
Yeah. When I worked at Seattle Mental Health in the late 80s, early 90s, they had a clubhouse model. Maybe they still do. It's now called Sound Mental Health, but it certainly brought consumers and persons with mental health out of isolation, like you say, in community. It was a non institutional environment. They could just sit and chat and have coffee, and I think it provided the relaxation for people to just kind of be who they are, and so I'm hoping they still have that in Seattle. But it was a big thing then. We actually did tours of different mental health centers that had clubhouse models. It was fairly new back then. But I'm glad it still exists.
It does, yeah. And I don't know that we have something active in Kitsap right now. If we do, let me know. But or I may just be overlooking it. But we're looking to pursue some future direction there too.
Yes. yeah, from my experience working in the psychiatric hospital, inpatient, like you are told to take this drug and take this drug, but when you getting better and outpatient, if no one is watching and you know, they don't want to take medication, they don't come back. So this outpatient group to support is very important. And do you know how long this group continue, or is that like if you have a drug addiction, that kind of group, or what kind of group do you have?
Yeah, so in our agency, people are free to continue with their group participation for as long as they're identifying that it's something that's helpful for them. It would be very rare for us to kick somebody out of a group, for instance. I think the bigger problem comes in our community with people who are who have just regular health insurance. You know, people who have, oddly enough, people who have more means end up in systems that are really focused on the bottom line, and they end up getting some basic services, but then they don't get the wraparound care that the Medicaid systems have really focused on. So I think that's unfortunate, but in those cases, you're right. A lot of people, they get some initial treatment, and then their insurances just kind of decide, okay, that's enough for you. You know, you've had your 12 visits, that's all you're allotted. And that's unfortunate. That's a bigger problem with our healthcare system that I think needs to be addressed.
That is this country's problem. From Japan, we have a different system. So, yeah.
So Japan, that's really interesting. I didn't know that's where you're from. So my understanding of the Japanese system is that there's a lot of focus on integrated health care, on not just jumping straight to medication and the health model, but looking at alternative treatments. And we're actually trying to pay more attention to that at KMHS, and possibly bringing in some focus on naturopathic care, just general wellness as a focus before focusing in on the pathology and the diagnosis and the treatment for that diagnosis. Let's look first at your overall wellness and see if we can address your habits and your understanding of what wellness is and your value system. And I think Japan does that better. I'm not an expert, obviously, in that area, but from what I understand, that's a direction we should be paying attention to. Were you a counselor in Japan as well?
Yeah, I was.
Yeah, am I understanding that correctly? Was that your impression?
I don't know. It was many years ago. At that time I don't think it's so wide, but outpatient is paid, and you know, so they can come more easily. Insurance is if you don't much income, according to income you paid. So
I see.
It's much easier to keep going.
I see. Right.
Yeah.
Anybody else?
Let's use his email.
Okay. So
I could do about something else.
let's see. Do any other thoughts or comments or questions, or you can see we're down to 7 people. But
can we still you put your email, you really invited us, but if we have some questions we think of, or we have questions that we need to follow through on that we don't want to burden the group with now, you're giving us the big okay to email you.
Yes,
Thank you.
absolutely. My my email is public. I think it's on the website. If you don't get it here, you can go to the KMH website and pull it off of that. It's not unusual for me to receive emails from people in the community who have questions about mental health care and what we can offer. So please feel free.
Okay.
Thank you.
Okay.
Awesome. Well, thank you, everybody.
Yeah.
Thank you, Jerry, and
Yes.
really appreciate your time.
This has been extremely valuable for me, and I'm sure others here too. It's just, I've learned so much. I had no idea you guys do so much. And I
Oh,
repeat what Bill says. I hope you stay here a long time.
oh, thanks, thanks.
Yes, wonderful.
Yes, don't hesitate to email me if other questions come up. I know that's I always think of things after these things are over, so don't hesitate.
Yeah, it's a nice thing about email. If it's 2 o'clock in the morning, I think of something, I could still ask it.
That's
So,
right. That's right. Get it off your mind and go to sleep.
yeah. Okay. Well, thank you.
All right,
Thank you,
guys.
Bill.
Thank you so
Everybody.
much.
Thank
Yeah.
you very
Thank
much.
you.
Have a wonderful Sunday.
Yes.
Thank you.
You too.
Oh, no.
Bye-bye.